Pucuk paku daun selasih, saya ucapkan terima kasih.
Biology, Riau University. First, let me introduce myself. I'm Novita Anggraini, the moderator of today's lecture. I'm very happy to see you here and welcome all of you. Today's lecture is about septic shock endpoints, updates, and current practice. And our speaker today is DATUK, Dr. ALZAMANI Muhammad Idrose, or known as Dr. Alza.
Yeah.
He's one of my best friends. We knew each other about 8 years ago, and since then we became a best friend. As long as I know, he's a multi-talented man with beautiful personality. He works as clinician in emergency department hospital Kuala Lumpur. He obtained a European Master in Disaster Medicine from University of Eastern Italy in 2004, a Master of Medicine Emergency from University Science Malaysia in 2006, a Bachelor of Jurisprudence from University of Malaya in 2012, a Fellowship in Emergency and Critical Care Ultrasound awarded by University Technology Mara in 17. A PhD in Sports Science and Recreation from UITM in 2020, and a Fellow of Emergency and Medical Critical Care Program. He's also the head of Pediatrics Emergency Department Hospital Tunku Azizah. He'd been appointed as a personal physician for His Majesty the 14th till 2016. And he was also a doctor for Malaysian Everest climbers in 20. He's been invited as speaker for hundreds times in local and international conferences or academic. And hundreds of publications in journals, book chapters, and articles. He has many prizes, awards, and honors. I guess I am honored to be his best friend until now. So now allow me for welcome the speaker, my dearest best friend, Datuk Dr. ALZAMANI Muhammad Idrose.
Assalamualaikum sekali lagi, and good morning to everyone. Terima kasih, Dr. Novita Anggraini. Yes, my very good friend from Pekanbaru, Indonesia, and I think it is an honor to be invited. Thank you for the kind introduction. Basically, I am a very simple person, but I believe in simplicity and simplifying things. I think life should not be too complicated. It should be simple. So may I start my presentation? So I shall share my screen. Just 1 second. Okay. Just a second, sorry. That didn't go. Can you see my screen? Just 1 second. Yeah, I think this is not the right one, but just 1 second. I'll just correct the slide because there is the Pekanbaru, which is the one. Okay, can you see my screen? Is this nampak tak? All good? Can you see my screen? And can you hear me loud and clear? Bisa ya? Bisa, doktor?
Bisa, dokter.
Okay, jadi saya boleh teruskan ya? Saya teruskan ya. Okay, hari ini we shall talk on sepsis endpoint, the updates and the current practice, plus a little bonus. I will also share about the evolving concepts. Yeah? So, jadi hari ini kita akan bicarakan tentang current practice, the updates, plus what's coming that is still in evolving that may become part of our practice in the future. So, okay, let's move on. So, when we say that the current practice is in managing sepsis or septic shock, we mostly follow the Surviving Sepsis Campaign guidelines. And actually, there has not been much changes since the last update. Yeah? And when we talk about septic shock, it is about abnormal blood distribution and even vasodilatation due to initial fluid resuscitation and fluid responsiveness. So when we look at some of the new vasopressors or inotropes being introduced, is still uncertain. There are still new concepts in fluid resuscitation being introduced. And there are evolving concepts in monitoring and managing septic shock. But anyway, let's look at this again. For people who have sepsis, why do they die? So somebody who has sepsis, meaning that all the organisms has gone to the bloodstream, going to all the rest of the body, and as a response, the whole body, the host responds by having this producing inflammatory elements, and these inflammatory elements in the form of cytokines. It's like a storm. They produce the cytokines, and as a result of all this, there may be a leakage of tissue fluid that it's supposed to be carrying oxygen and nutrient to the tissues, and there may even be, because of the inflammation, some microthrombosis that blocks the circulation to the tissue. So as a result of that, the tissue is starving of oxygen and nutrient, and when they starve of oxygen, they get tissue hypoxia, and when there's more tissue gets hypoxic because they do not receive the oxygen, you have a global tissue hypoxia. I mean, so much part of the organ tissue die. Then when that happens, the organ die, the organ fails, and after the organ death or organ failure, then you die. So the problem is very much like this. If I were to simplify it, we live because there is oxygen, and plus there is circulation to our body, to our tissues. So for the oxygen to flow to our tissues, can imagine like this river that flow from the upstream, and they will flow to the downstream. This is where, if you imagine that it's like your capillary, it's like going to your house. So if there is any blockage stopping this river of water coming to you, you will have trouble. You do not get the water and you will suffer. So it's the same with our body. For the oxygen to get to the tissues, you will need the blood, the circulation that carry the oxygen, meaning that there has to be adequate blood, and then the flow is not interrupted through the dam and through the heart, and then the water or the blood goes to your tissue with no disturbance at the downstream. So this is The upstream is a macro circulation, meaning that the fluid, the water, the damp, the pump. But downstream is about at your capillary levels, your tissue levels, very much at the cellular levels. So this is what it's all about. When somebody having sepsis, with all the inflammation, with the fluids leakage, this blood is not getting to the tissue and the tissue die. So yeah, this is when we talk about macro circulation, we can look at this, all this part, the volume inside, the fluid, the blood, the heart that pumps that blood to the tissue, and then the pipe, the vessels that bring all that blood to the tissues. Yeah, so we're talking about for macro circulation, there has to be enough fluids in the circulation for the oxygen to be carried to the tissue. And not only that, not just filling up this circulation, these pipes with enough fluid, we also need a good functioning pump. We need to have a good cardiac output. And if we do not have enough pressure inside, during sepsis with all the inflammation, there tend to be vasodilation of the vessel. So we need to press the vessel, so that there will be enough pressure inside that would carry all the circulation to the tissue. So this is the macro circulation. So if we looking at the endpoint today, meaning that what is our target when we resuscitate our patients, that we are really addressing the problem of the macro circulation. We have enough fluid, the pump is running well, and if it's not well, it should be supported. We're talking about the pipes. If the pipe is is dilated, it needs to be pressed. Therefore we use the vasopressors. All this is addressing the problem of macro circulation, so that we get a minimum blood pressure that would carry all this fluid to the tissue and ensure the tissues get all the oxygen. So this is the macro circulation. Yeah. So for the vessels I mentioned just now, you may need to use vasopressor or vasoactive agents. So with all this, you have fluid, you have the good pump, you have the heart functioning, and the vessels. All this would give rise to mean arterial pressure. All this. Yeah? So to achieve a minimum mean arterial pressure that will serve the whole body, you need enough fluid, you need a good functioning pump, and you may even need some vasopressors, especially when the blood pressure is low, to keep a minimum mean arterial pressure that could supply the circulation to the tissues well. And when we look at the micro circulation, from the macro circulation, we got the river flowing. We need to look at the problem downstream. So these are the elements that we look at, because if you see, we're talking about the tissues at the downstream, at the liver, at the kidney, at the gut. So with all this, we could check whether at the cellular or at the tissue level, at the microcirculatory level, we are achieving enough delivery of the oxygen. And that we know by checking these elements. The difference between the venous and arterial carbon dioxide, the capillary refill time, the lactate, the central venous saturation, the mixed venous saturation, and the urine output. All this could tell us whether we are achieving our resuscitation well, so that the tissue doesn't die, the organ doesn't die, and there wouldn't be death. So bottom line aim in any septic shock is adequate and organ perfusion. Any research that has been done and will be done would be based on this. If you could find a solution for adequate and organ perfusion, you would be able to save patients with sepsis. That's the bottom line. But of course, there are lots of challenge in addressing that. So these are the resuscitation endpoints. Yeah? At the initial phase of resuscitation, we have to target the microcirculatory endpoints. We have to make sure that there's enough fluid, the pump is working, and also the vessels is not vasodilated to the point that it ends up with the mean arterial pressure being low, the pressure inside being low. So that is at the macro circulatory level. So we have to ensure, and we could look at it in terms of intravascular fluid volume status, the mean arterial pressure, and the cardiac output. Then, once we're done with this, we need to assess whether from the upstream, at the downstream, the heliorrhea, there is no trouble, there's no blockage. So we know that the tissue is receiving that perfusion by looking at these microcirculatory endpoints in the form of lactate, of this central venous oxygen saturation, the gap, the difference between central venous and arterial carbon dioxide, the capillary refill time, and the urine output. All this, if we check that they achieve the good number, then we know we are on the right track to save the patient. So this is the outline of this presentation today. I shall dwell in terms of microcirculatory elements in the form of fluids, vasopressors, inotropes, vasoactive drugs, mean arterial pressure, cardiac output, as well as the microcirculatory elements in the form of lactate, mixed and central venous saturation, capillary refill time, urine output. I shall dwell on each of these elements in terms of the updates, the current practice, and on top of that, as a bonus that I promised you just now, I will also talk about the evolving concept. What's new as regards to all these elements when we resuscitate patient. Okay, so let's look at macro circulation. For macro circulatory endpoint, we can focus our attention to intravascular volume status in terms of whether the pipes are filled with enough fluid. And we could do that by looking at all these elements when we want to test as an endpoint. The central venous pressure, we could see whether we have achieved the desired number, the IVC, inferior vena cava variability, by using the ultrasound. We could test whether patient can take more fluid or not by using the passive leg raise test. We could also look at the pulse pressure variation. In my emergency department, we do not have intra-arterial blood pressure, but at your ICU, you will have that facility to also help you guide that, knowing that whether this patient can take fluid more or not. We could look at the stroke volume variation, either using the echo machine. We could also, if you have, but this is very invasive, the pulmonary artery and expiratory occlusion test. Okay, that's in terms of assessing the intravascular volume status, the fluid. Then we need to know also whether the pump is working. Then for that, we can assess the cardiac output by using our echo machine. We could actually calculate the cardiac output, but it takes a bit more calculation. But there is a simpler way by looking at the left ventricular outflow tract VTI, LVOT VTI, that you could actually place your pulse wave Doppler at the aorta, and you could get that reading. And this is in terms of cardiac output. But there is also an ultrasound base whereby you don't have to look at the image so much, but you just need to place it at the correct angle, and it will read continuously this USCOM, and will even give you the value, for example, the stroke volume and even the cardiac output. If you have the machine, it costs about like 200,000 Malaysian ringgit. And you could look at the mean arterial pressure, and you could just measure it non-invasively, or if you have intra-arterial blood pressure. So there is if you have, you could ensure that the fluid is well filled, the pipes well filled, and you know that you have a target number of the mean arterial pressure. Then if need be, you may have to add vasopressor. And when you look at the cardiac output, if it is low, because sometimes patient with sepsis can also get septic cardiomyopathy. The heart is not pumping well because of the sepsis, and you may introduce some inotropic agent. So let's take a look at all this. Okay, first we take a look at the fluids. So now this is the problem. How much fluid should be given? Actually, there's no clarity for optimal amount of fluid in large randomized control trials done before this. For example, in the process, ARISE, PROMISE. So we have to titrate individually. But in general, we start fluid resuscitation to keep this magic number of MAP 65. Okay, so we can have, according to the sepsis campaign guideline, that you could have a fluid challenge of 500 ml for intravenous crystalloid solution up to a maximum of 30 ml per kilo within the first 3 hours. This is what the guideline recommends, and can be an additional crystalloid with the objective of clinical findings suggesting that adding fluids would improve cardiac output and organ perfusion. But over resuscitation would lead to third space fluid accumulation and would reduce the delivery of oxygen to end organ tissues. So these are the issues. So to assess whether we have put in enough fluid or not, we could look at this assessment in terms of a static way or dynamic way. We could use a static way to measure at a single point for preload assessment, meaning that we have enough fluid or not, by using the central venous pressure or pulmonary artery occlusion pressure, which is more invasive. Or we could use a dynamic way, which is a better positive predictive value, sensitivity and specificity compared to static method. And for this, we could use the inferior vena cava variability. You could use the stroke volume variation. This could also be viewed through the intra-arterial blood pressure waveform analysis. This pulse pressure variation. The stroke volume variation, we could use either the ASCOM, or we just use the echo machine, bedside echo machine, and look at the VTI as a representative of the stroke volume. Okay, now for the assessing whether the patient is fluid tolerant or not. Remember, we want to titrate, despite the general sepsis guideline is stating that you should give like 30 ml per kilo in a matter of 3 hours in resuscitating patient with a septic shock. So we also know that patient may have heart problem, they may have a kidney problem. Therefore, you cannot give 30 ml per kilo over 3 hours. You have to titrate. In fact, you may have to start with something as low as 3 ml per kilo and then assess whether patient can tolerate more fluid or not. And this is one of the ways to assess a patient's fluid tolerance. So we could use a passive leg raise test like this, and we could measure if there is, when we flip the patient like this, we could look at the pre and post in terms of, okay, you could look at the difference of pulse pressure before and after. Usually, we put the patient leg up position like this. It is kind of auto-bolus, meaning that we give patients fluid from patient's legs, which is equivalent to about 300 cc of fluid going up, and we could measure the pulse pressure before and after. For pulse pressure, if you have intra-arterial blood pressure, it's easier. You could look at the difference between the systolic and diastolic. And I put here a clock, a wall clock of showing 12 o'clock, meaning that if there is a difference of 12%, more than 12%, that would mean that patient is fluid tolerant. They can take more fluid. The other way, if you have stroke volume or cardiac output measurement before and after, this you could get if you have that expensive ASCOM machine. But if not, you could put your echo probe and measure the VTI, because the VTI is representative of the stroke volume and cardiac output. And again, if there's a difference of more than 12% or more, then that means patient is fluid tolerant. So that is using this technique to assess the fluid. If you're using the central venous pressure, this is the traditional way to determine whether patient has enough fluid inside or not. But this is the target that is recommended, between 8 to 12 millimeter mercury in a spontaneously breathing patient, or between 12 to 15 millimeter mercury in mechanically ventilated patient. So the problem is this is quite unreliable, and even the positive predictive value is only 47% for fluid responsiveness. And it's also invasive because you have to insert a central line. So, but if you have it, if you want to measure, this would be the number, the endpoint. Now, if you have the ultrasound, this is a non-invasive way. And if you are able to put your probe at the epigastric area of your patient, the normal size is usually between 1.5 to 2.5 centimeters. Sorry about this. And it is we said it's well filled if it is about this size, about 2 cm, with a collapsibility. And you'll see this is a IVC will vary when you inspire. If you're not intubated, when you inspire, it will collapse. And if it is more than 50%, meaning the difference is more than 50% between the expiratory and inspiratory diameter, then this patient is fluid tolerant. But if it is less than 50%, the size is about 2 cm, then this patient the fluid has been filled up very well. For ventilated patient, it's different because it's a positive pressure ventilation. We're not looking at the collapse, we're looking at the distension. During inspiration, there will be distension of more than 12%. Some paper says more than 18% to show that this patient is fluid tolerant. But this has to be in a well-sedated patient receiving tidal volume in the studies done at 8 mL per kilo. So nevertheless, there can be many factors that could affect this, the accuracy of this, because patient may have heart failure, patient may have pulmonary embolism, patient may have valvular heart disease, which may cause the IVC to be falsely dilated. So we have to take into account of patient existing condition. And in fact, it's good. In my practice, I used to look at various parameters. For example, if I look at the heart by itself, if the chambers is very small, it's almost collapsing, meaning that that is true, that patient is underfilled. So this is some of the evolving concept that nowadays people are talking about. First, you have the salvage phase, whereby you increase the blood pressure in hypotensive patient, and you give fluid and even start vasopressors if the MAP is not achieving the target of 65. Then the period of optimization, looking at the tissue perfusion and oxygen delivery, you may look at whether there is the target of the microcirculation has been achieved, and you go on to the period of stabilization, whereby you decrease in terms of fluid balances and weaning of vasoactive medication while maintaining adequate tissue perfusion. You just want to look at the fluid balance to minimize it, and then the de-escalation, whereby you start to restrict fluid and even remove excessive fluid. So that's regarding fluid. Now we move on to vasopressors. We're talking about the pipes, yeah, the pipes that may not be having enough consistency because of the effect from sepsis. So this is the recommendation that there should be early initiation of vasopressor, that even during the initial phase, even the first half an hour, giving fluid, the blood pressure, the mean arterial pressure is not hitting the minimum of MAP 65, the vasopressor should be started fast, concurrently even. There is a 5.3% mortality increase with 1 hour delay of vasopressor initiation. And this is the in the Surviving Sepsis Campaign 2018, noradrenaline is started if still hypotensive during or after fluid resuscitation in order to maintain an MAP of 65 and above. Peripheral vasoactive infusions is acceptable, meaning that initially we do not manage to get the central line yet. Actually, this is still acceptable, but in a short period, up to 48 hours, to help achieve the MAP 65. Sometimes due to logistics reason, the patients could not, the central line could not be set early enough for you to give the vasopressor, but do not wait for that. You could still give it through the peripheral line. So this is the thing about being giving simultaneous fluids and vasopressors. This is if you delay starting it, you would increase the mortality. So these are the benefits when vasopressor fluids are started simultaneously. You'll be using less fluid. There will be lower net fluid balance, shorter duration of hypotension, lower incidence of pulmonary edema, and even lower incidence of arrhythmia. And systematic reviews have shown decreased short-term mortality with the simultaneous fluid and vasopressor initiation in septic shock patients. Then we move on to talk about the noradrenaline is the mainstay of the vasopressor, and that should be the agent started. But there may be other agent that you can be added, for example, vasopressin. So if noradrenaline has been started and it has already reached beyond 0.5 mic, even some papers suggest beyond 0.25 mic per kilo per minute, vasopressin should be added. If the cardiac function is not good, then adrenaline can be used because it has both the vasopressor as well as the inotropic element or effect. And hydrocort can be added as well to achieve the MAP of 65. So this is some of the recommendation. You could opt for after going using noradrenaline. You still not hitting the target after 0.2 even here, mic per kilo per minute. Then you could add either adrenaline or vasopressin. If patient has the cardiac contractility, the pump is not good, then this can be preferred. Okay, now this is from a sensor study in Thailand. So in this study, this is the first prospective randomized trial looking at vasopressors and sepsis in Thailand. And those who are septic with an MAP less than 65 were randomized to receive noradrenaline without titration for 24 hours or placebo. And 76% in the group that received early noradrenaline achieved shock resolution within 6 hours. And mortality was found to be lower with the early noradrenaline group. So this gives a stress in terms of the need to start the vasopressor early in patients with septic shock, those with the MAP less than 65. So from vasopressors, let's move on to look at inotropes. Excuse me. Okay, after adequate volume resuscitation plus vasopressor support, so we can look at the cardiac output, and this we could use the bedside ultrasound or the echo. And if you are able to measure based on patient body surface index, you could measure the cardiac index with the echo. The machine could calculate it for you. If it is less than 2.2, meaning that it's not achieving desired function of the heart. And so for this, or even just for me, just by looking, if the cardiac function is not good, then you can add an inotropic therapy. And dobutamine is currently the recommended first-line inotrope for septic cardiomyopathy. So as an alternative, you could use adrenaline, but one problem with adrenaline, it would affect lactate clearance. In fact, the lactate can go high with the use of adrenaline as inotropic agent. So this is something for you to bear in mind as you are trying to look at the indication whether your resuscitation is working or not, because lactate is one of the parameters. So I would just touch this thing when I put on the blue slides. It's about the evolving concept regarding this inodilators and vasoactive drugs, which is still evolving, not yet as recommended in our practice. So this is some of the evolving concepts. For example, there is this concept of trialing of dobutamine, whereby a limited dose of dobutamine is used as an inodilator test. And the target parameter is then seen. If beneficial, it is maintained. So this is some people started to give a trial of dobutamine, whether to continue or not when they look at the patients not achieving the endpoints, the MAP or even the microcirculatory endpoints. So these are some also evolving concepts as analogs of vasopressin. Remember just now, we can add vasopressin, but these are some being studied in terms of terlipressin, celepressin, even angiotensin 2. But so far, it is not encouraging. The results doesn't show good results, but there are even digital ischemia. So it's just doesn't look promising, but it is still evolving. They are still studying it. There's also the use of angiotensin 2, but they found it's not good for patients, but it's beneficial to patients with acute kidney injury requiring renal replacement therapy and elevated renin levels, because there was a significant mortality benefit. So because of that, it's still evolving. There are, in terms of inodilators, for example, calcium sensitizers like levosimendan, phosphodiesterase, like milrinone and inoximon. At the time being, for example, like levosimendan, if no cardiac function, there's no improved morbidity or mortality. In fact, levosimendan is not superior to dobutamine, which is cheaper. For phosphodiesterase 3, there's experimental benefit, but no clinical evidence. So still, we go back to dobutamine or adrenaline. So this is some evolving concept, the use of dexmedetomidine in septic shock patient. It functions by attenuating sympathetic response and decrease adrenaline levels, but maintains tissue perfusion. So it showed a faster resolution of the high lactate and even reduced no adrenaline requirements. But the outcome, clinical outcome, has not yet been determined. So this is evolving. In the future, you may be able to probably opt for dexmedetomidine for sedative agent, but from helping patient in septic shock because it helps in the tissue perfusion. But it is the evidence is not solid yet. The other one is the use of esmolol, a beta blocker, in experimental studies showed favorable effects on heart rate and some hemodynamic inflammatory metabolic variables, including a decrease in blood lactate levels. So this is still evolving, the use of esmolol. And another one, even the use of methylene blue. Apparently, it works by reducing nitrite oxide by blocking guanylate cyclase. And there's a small size studies currently with conflicting results. So methylene blue is being investigated as one of the agents for septic shock. Okay, now we move on from the pipe problem. We move on to the sort of an outcome from the pipe and the pump and the fluid prop that gives rise to mean arterial pressure. So, so this is when we talk about mean arterial pressure, when we say sepsis-related arterial hypertension, when we talk about now with the systolic blood pressure less than 100. In the past, we took 90 as the number, and MAP less than 70. So, or a decrease of more than 14 adults, or less than 2 standard deviation below normal for a given age. Anyway, it's easier to put your mind to 65 because it's kind of a well-accepted number of MAP, 65, less than that, you know. And plus, in general, if you see the systolic blood pressure less than 100, then this patient is in shock. So from evidences that we have, targeting higher MAP, higher than 65, does not reduce organ dysfunction or improve global outcomes. But for some patient with certain condition, it may improve microvascular perfusion. So this is a study, a sepsis pump study in 2014, that showed that a patient with a chronic hypertension, if they are given higher MAP of 80, they would require less renal replacement therapy. So this is a higher MAP of 80 should be reserved for those who have an underlying history of chronic hypertension. Okay, now we look at the pump, the cardiac output. Most sepsis have warm shock. They are hypotensive plus warm skin, bounding peripheral pulse. But there are also patients with sepsis with cold shock, meaning that the cardiac output is not good. So sepsis can affect the cardiac function. It could cause septic cardiomyopathy. So for someone with a cold shock, there may be a pump problem. So sepsis-induced cardiac dysfunction, or even in late phases of septic shock, it could cause a cold shock. So in assessing cardiac output, the pump, you could use the echocardiography, and cardiac index is given by a cardiac output over a body surface area. This is what I mentioned just now. If it is to be calculated to achieve that 2.2. Anyway, we could easily look at the VTI, and this is representative of the stroke volume and cardiac output. There are also more advanced monitoring devices that actually analyzes the pulse wave contour, like LICO, PICO, flow track, but it's very expensive. Maybe you have it at your center, but I don't in my emergency department. We are not that rich. You could also use a SCOM machine, which is actually an ultrasound machine that could assess multiple parameters of the cardiac, including the stroke volume, variation, the cardiac output. And there are also other things like bioreactance, measurement system like NICOM, invasive cardiac output monitoring devices, all these which are invasive pulmonary artery catheter. But usually these in patients with cardiothoracic surgery, they usually have that. So let's look at a microcirculation. Just now we have finished the macrocirculation. Now we look at the microcirculation. Microcirculation is a network of arterioles, capillaries, and post-capillary venules. And this is like at the downstream. And it is where the delivery of red blood cells and plasma to organs with cellular exchange of oxygen, carbon dioxide, nutrients, cytokines, and metabolic waste removal happen. So this is crucial because if the macro circulation is good, but the micro circulation is not good, then the tissue will die, the organ will die. So in sepsis, there may be sepsis-induced inflammation, coagulopathy, leukocyte dysfunction, and even nitric oxide production that affects microvascular blood flow. There can be an imbalance between the oxygen delivery and the demand. So now we have this, excuse me, a study of microcirculation whereby they have a camera called cytocam that they put under the tongue, and you could look at a normal microcirculation versus an abnormal microcirculation in septic shock patient. It is not normal, and in fact there may be some blockage at that level. And this is the problem, or what I call trouble at downstream. You may have shunts, you may have thrombosis, there may be congestion, there may even be hemorrhage, viscosity alteration down there, redistribution, microvascular permeability, deformed red blood cell that carries the oxygen. So all that contributes to an inefficient microcirculation to the tissue, and that can cause tissue hypoxia and tissue death. So this is the handheld or the cytocam that could actually look at this microcirculation. And this is still evolving, and whether it could change our practice if we have that device is still an evolving concept. Yeah? So this is what we call sublingual microcirculation. Yeah? They put it under the tongue, and with this, the peripheral perfusion is actually assessed. And in the future, they may actually assess the red blood cell velocity, the flow at that level, the glycocalyx, even the patterns of the microcirculation dysfunction. But this is still evolving. Okay, now we look at lactate. So for lactate, all right, so this is a diagnostic marker too for sepsis and septic shock. And a level of more than 2 signifies sepsis-induced organ dysfunction. And usually it is between 0.5 to 2. And it helps us to identify occult septic shock. Sometimes we don't, the blood pressure is normal, but you still have a lactate higher. But the problem is that it is not specific and can have many false positives. So actually any type of shock, not just septic shock, can be hypovolemia, it can be obstructive shock, it can be distributive shock. It can give rise to higher lactate. In aerobic glycolysis, even patient with having enough oxygen also can give rise to lactate. Patient with liver failure, patient having seizure, patient having mesenteric ischemia, for example, those using the salbutamol, and even when you use adrenaline, which I mentioned just now, can give rise to high lactate. So this can mess up our interpretation of microcirculation. So apart from lactate, we can look at other things. For example, the mixed and central venous saturation. So both of them actually give an estimation of the global balance of cellular oxygen delivery and the demand. And if the level of the central venous saturation is less than 70%, it means that there is an inadequate delivery of oxygen to tissues, or increased extraction at that level, or both. So the central venous oxygen is targeted between 70 to 89%. And this actually correlates well with the mixed venous oxygen saturation between 60 to 70%. So if it is supranormal, too high, more than 90% is not good as well, because it would mean higher mortality, and it reflects poor oxygen utilization, tissue dysoxia, or significant microcirculatory shunting. So when peripheral lactate is compared with the central venous oxygenation optimization, there is no difference. So this takes more cost because you put into the machine more, check more. Currently, the routine use of the central venous oxygen saturation is not incorporated in the protocol. The other way to know about microcirculation is to measure the gradient or the difference between the central venous that you take from the central line and the arterial carbon dioxide. And a normal or high central venous oxygen saturation cannot determine adequate organ perfusion by itself. But when you get this difference, if the level is less than 6, it will reflect an adequate cardiac output and adequate microcirculatory flow and perfusion. So it is quite a powerful method to actually assess cardiac output and macrocirculatory flow indirectly. So you subtract the CO2 from the central and the arterial, and the magic number is 6. So it indicates a higher cardiac index, even better lactate clearance, and improved macrocirculatory perfusion, and in indirect marker of blood flow. Yeah. So when it is more than 6, it means a hypoperfusion. So 6 is a magic number. Yeah. But there's some problem that it can be normal even with preserved and high systemic flow as well. Now we look at the capillary refill time. So this would very simple to do at the bedside. Touch your patient, and then you could see whether it is 3 seconds or more. You should be less than 3 seconds in healthy patient. So if it's delayed more than 5 seconds, especially, suggests abnormal microcirculation. So we can do a serial CRT with normalization at 6 hours, means that we have successfully resuscitated patients. If we have delayed CRT, post-resuscitation is a predictor of worsening organ failure and shock. So this is pretty powerful. And this is how it's done. Even this paper, they use normal, they take it at 3.5 seconds, a bit longer. So there's this study in 2019, the Andromeda shock study, that showed when you compare the CRT, when you use the lactate clearance as a biomarker for resuscitation, they found that those groups using lactate as the endpoint, they use more fluid, more vasopressor, more adrenaline, and no significant improvement compared to those that they just use CRT, which is non-invasive and free and cheap. So in fact, there's a higher 28-day mortality in the lactate clearance group compared to the CRT. So it's very good method to assess your success of resuscitation. So there is of course, some problem with some patient having cold, clammy skin, cold ICUs. But now in something evolving, that there's company developing optical devices that may allow continuous assessment of peripheral perfusion. That's wonderful, right? So it's still in the works. Yeah? Probably in the future, you could attach it just like you attach the oxygen saturation device. Okay, then we have urine output. This is also another marker of microcirculation. And usually we target to make sure that the urine output is more than 0.5 mils per kilo per minute to reflect adequate renal perfusion. So this is the preferred fluid is balanced crystalloid. And actually the hypochloremia, chlorine, hypochloremia is not good because it's actually a vasoconstrictor. Chloride is a vasoconstrictor of the renal artery. So in resuscitation, a balanced crystalloid is preferred compared to just the normal saline. So other evolving concept, I'm just touching very quickly, is that this is some of the things that will be used probably in the future. Diastolic shock index, the coupling between pump and vasculature, vasomotor tone, and it's complex, requires modeling and not easily used at the bedside. So this is the other thing, the use of the pulse pressure variation, stroke volume variation, EDIN, dynamic arterial elastance to identify patients who will increase the MAP when CO2 is increased by fluid challenge. So these are still evolving, and we may see this taking place in the future. So in terms of refractory shock, the use of steroids and vitamins, hydrocort is established. You should use it if you are using, after using 2 inotropes or a higher vasopressor level, then you should actually add hydrocort. But currently there is no role of vitamin that is clear. from the larger studies like vitamins and citrus ali, there was no benefit with the use of vitamin, all that vitamin C, thiamine. Yeah. So this is some of the evolving concept, extracorporeal blood purification techniques. Remember, we were talking about cytokine storm. We want to clear the cytokines. So it's still evolving. And also the use of ECMO, which is expensive. But there's a lack of sufficient clinical evidence. So general recommendation could not be made to recommend ECMO for a septic shock patient. And there's a need to individualize patients. So I've come to the conclusion of this presentation. So it's a 1-hour talk. So the pillars of hemodynamic resuscitation have not changed much in general. And we have to individualize patient. There's new information on how to optimize fluid administration and the use of vasoactive drugs. There are many new aspects of macro circulation and micro circulation evolving concept, but they lack solid evidence. And there's a need of broad research agenda to focus on individualization and phenotyping of septic shock in the future. So again, to summarize, you should be grateful to the river of life. Make sure you have a beautiful river and no obstruction. And just like you're having a flow of river in your body with the blood inside, with the fluid inside, with a good pump, with a good pipe, with the vessels, and at the end, at the microcirculation level, they are functioning really well. And these are the things that you would correct for someone having septic shock. So in a nutshell, these are the macrocirculatory endpoint at the upstream, whereby I put this clock of that shows 8 and 12. 8 o'clock clock, because when you look at the intravascular volume status, you might, if you use the CVP, you want to target it between 8 to 12. If you look at the passive leg raise test, also you're actually looking at number 12, that if there's an improvement of 12% of the pulse pressure or the VTI or stroke volume or cardiac output. In terms of the IVC variability, we talk about for those patients who are not intubated, we're talking about the size is less than 1, so 1 and 12, right? And if it is well filled, if the size is about 2, they're in mechanically ventilated patients, you look at the distension of the IVC rather than the compression, and that distension, the number is also 12%. So in terms of mean arterial pressure, the magic number is still 65, except for those with the chronic hypertension that you could aim for a higher MAP at 80. And those with the cardiac output, again, you look at the echo and the VTI difference of 12 in the passive leg rate test, or even when you look at the VTI pattern, there's a variation of 12%. Also indicate that patient is fluid responsive. And in terms of the microcirculatory endpoint, these are the magic numbers, the downstream. You want to keep, if you do use the saturation, which is not actually recommended routinely, you want to have it more than 70% central venous saturation. If you really want to have in a reflection of these patients receiving good cardiac output as well as tissue perfusion, you could use the gradient of the central and arterial carbon dioxide to be less than 6. And when you're looking at the lactate, it should be less than 2, but be aware if the patient is having a liver problem or using nebulizer or adrenaline, the level may be higher, and you aim your capillary refill time should be less than 3 seconds, and you should make sure the urine output more than 0.5, because these two, the simple one, would reflect the your endpoint of the microcirculation. So we're having a conference coming soon, 17 to 18 October. If you're in Malaysia, you're welcome to join. So thank you. Back to you, Dr. Novita.
Thank you very much for giving such an informative lecture. Dr. Alza. Now are the time for question and answer session.
Yeah.
First, perhaps I would like to have 3 questions. Then, let me see the chat. Oke, langsung aja. Langsung. Citra ya, Citra. Citra boleh langsung. Ini ada pertanyaan. There's a question from my students. Citra, boleh langsung Citra.
Baik dokter.
Yeah.
This is interactive discussion, Citra.
Ya, dok.
Hello.
Assalamualaikum warahmatullahi wabarakatuh.
Salam.
Thank you for the presentation, Doc. I would like to ask some question about the sepsis.
Yeah.
The first is about taking about steroid drug for sepsis and sepsis.
Yeah.
What kind of steroid that we can use for sepsis and shock sepsis? But you talk about hydrocortisone. Can we know the hydrocortisone or steroid can induce the stress ulcer or hyperglycemic for the patient? So for the patient sepsis or shock sepsis, it also can induce stress ulcer, but we can use this steroid. What is the explanation about the steroid? The second question, with the patient with sepsis or shock sepsis, we can do treatment with operation to shock control. So what kind of the parameter that we can use for the patient? It can be it's normal, or it can be to get operation. What's parameter that we have to use for the patient? And also to the campaign for sepsis with the fluid regimen in 3 hours. First 3 hours, we can give 30 milliliter per kilogram weight. But after the 3 hours, how many fluid that can be given for the sepsis or shock sepsis patient? Thank you, Doctor.
Okay. So thank you for the question. There are 3 questions. I will try to address it. Number 1, the question is about steroids, and there is a question about the choice of steroids. What kind of steroids? And number 2 is also the concern for patient with sepsis developing stress ulcer, which is a concern for everyone. It's a genuine concern. Number 1 is that the hydrocort is established to be used. I believe is because when we talk about someone having septic shock, it's about organ failure, and one of the organs involved is the adrenal, and you can get adrenal insufficiency. So hydrocort has the characteristic of a mineralocorticoid, which is also partly produced by the adrenal gland. So hence, I believe that is the reason why hydrocort is preferred to be used. And this steroid is only used if you are using a significant amount of vasopressors. What is significant? I think once it has crossed the threshold of 0.5 mic, I think that is considered significant, because there is also a point when you're already considering to add a second inotropic agent. Hydrocort is established in the Surviving Sepsis campaign to be used, so it should be used. But number two, when we use this, we're also concerned about the stress ulcer, and all patients that is having septic shock, they should be covered with the proton pump inhibitor. And this also should function to also negate the stress ulcer. And on top of that, because we have discovered giving a hydrocort on top of that would not, the risk would be addressed by this concurrent proton pump inhibitor administration. That's number one. Number two, in terms of this operation, the parameters that would be lovely for patient with sepsis or septic shock to undergo operation. I have to be honest, I am not an anesthesiologist. This is best answered by Dr. Novita, but for me, principally, I still believe that such patient going through the operation, you still need to maintain the basic macro circulation, meaning that you need to achieve the MAP as stated of 65, unless the surgeon wants it to be higher for some reason. So you will still fight for that to be the minimum, but I think Dr. Novita could give a better explanation on this, or even you, if you are an anesthesiologist. Number three, in terms of the 3 hours. So again, we hit the number of this 30 mils per kilo per hour. This 30 mils per kilo in 3 hours. We hit the number because it's not backed by science, but it was just an observation from the Promise Process Arise study. They observe when they recalculate retrospectively, that's the amount of the fluid given in that study. So they said, okay, that should be the amount given, but it's not backed by science. But the correct perspective should be, we have to individualize. My patients, I don't actually target 30 mils per kilo in 3 hours. I would individualize them. I would start, if they have a good heart function, with 10 mils per kilo first per hour, and then reassess. And of course, I have to look at the baseline function of the heart, because if the heart is not good, I'm not going to give that 10 mils. I would give half, like 5 mils per kilo, and reassess. So we have to individualize the patient. That number is for me actually just what I stated, what the guidelines say, but I hate the number, to be honest. But I would individualize my patient. And the question is that after, if you do give to 30 mils per kilo, what next? For me, even if before reaching 30 mils per kilo, I find that the pipes are well filled. I look at the IVC variation, or I'm quite satisfied. I would not give another 10 mils. I would just straight away put patient on maintenance. And usually that maintenance would mean like continuing with 4 pints in 24 hours in general, if the patient has a good functioning heart. Yeah. So I hope that answers the question.
There is, I think it's answer well. About source control, perhaps already clear. Still, we have to optimize the patient. Perhaps we can go to another patient from Rido. Sorry, Doni. He is asking about mottling. Donny,
Yeah.
you can direct.
Yes, thank you, Doc. Thank you, Doc, for the presentation. I would like to ask the question. As your presentation, mottling is a sign of to start fluid resuscitation for septic or shock septic patient. Is there any limitation or consideration for patient with renal impairment or cognitive heart failure patient? Thank you.
Okay, let me understand your question. So mottling is a sign to start fluid, right? Subsequent to that, what was your question? Compared. Saya rasa ada tulis ini. Mottling is a sign to start fluid resuscitation for septic patient. Is there any limitation or consideration for patient with renal?
Mottling is a sign to start fluid resuscitation.
Yes, I get you. Yes, of course. I am also a head of pediatric emergency department. So one of the things that we look out for at the triage counter is the signs of mottling in children, because that is also a sign of shock. Mottling is even worse than delayed capillary refill time. It's really the skin is already showing that the child is not having enough fluid. Yes, the resuscitation is the same that we would pursue. In general, we want to get 10 mils per kilo per hour. If you notice, the guideline says by 3 hours, you get to 30 mils per kilo per hour. In some, even in children, we even go to 20 mils per kilo per hour. But in children, we know the heart is usually functioning well. But you rightly said that we have to have a concern of two things: of the pump is not working well, and the kidney is not working well. One is the problem of that you're going to congest your lungs because the pump is not working well. The other is that you're going to have the problem to congest your lungs as well, because not enough fluid being kicked out from a dysfunctional kidney. So this is why the keyword of individualization is stressed. So every patient, like I said, for me, that guideline is for a normal patient, but we have to individualize it to a patient with an underlying, for example, congestive heart failure or renal failure, for which we would challenge it slower. And it would go like even like something like 3 mils per kilo and reassess. And if you, this kind of patient, you start first, but mottling, usually they would need more than that. If patient have underlying congestive cardiac failure or kidney failure, you could go with 5 mils per kilo per hour first and reassess. And subsequent to that, the best way to know whether this patient will take more fluid or not is to do the passive leg raise test, which is an auto bolus test. You're not adding any fluid, but safely looking by transporting the fluid from the both legs and seeing that when you give about artificially giving 300 mils of fluid would actually improve, or there's no improvement. If there's no improvement, you should not give more fluids. It's enough, and it's enough to give only for maintenance. Yes. The next question.
Lots of questions.
Okay.
For you, Dr. Azam.
I can read.
Here's another question from Tania.
Tania. Oh, okay. Tania, izin bertanya. What the best timing to start?
When is the best timing to start?
When patient come, number one, I look at the systolic blood pressure. Is it less than 100? I start fluid first. And if the patient in general, no underlying history of failure or renal failure, I would go straight away with that 10 mils per kilo per hour. As patient fluid has started, and I look at the blood pressure, whether I'm achieving the MAP already or not. As soon as within 15 minutes, and if I don't achieve the MAP within 15 minutes, I would straight away start the vasopressor concurrently. So I don't wait. This is very much stress for you to start the vasopressor early. So how early? Some people said within 30 minutes. I would say within 15 minutes after starting fluid. Usually if you start fluid and you achieve the MAP 65, then you do not have to start the vasopressor. So that's for Tanya. Then I see here Abitri, right? Izin bertanya, pada 3 jam pertama, apakah harus tercapai 30 ml per kilo? Jika pada pasien telah terdapat tanda insufisiensi ginjal atau ALO atau MOF, bisakah langsung kombinasi vasopressor atau inotropik? Okay, first question first lah. Like I said, I hate the number of 30 ml per kilo. Please individualize. Sekiranya mereka ada masalah jantung atau buah pinggang, they should not be given that fast. Mulakan yang sedikit dahulu. Even kalau end stage renal failure, mulakan 3 ml per kilo dahulu dan reassess. Bisakah langsung kombinasi vasopressor atau inotropik? Iya, betul. Kalau pesakit mempunyai masalah ginjal terutamanya, vasopressor yang pertama adalah noradrenaline. Dan kalau kita sebenarnya kalau ada papers yang actually support that when you add vasopressin, it will reduce the renal replacement therapy. Vasopressin is pretty good in a paper in France paper kalau tak silap saya, that it is useful to be added to noradrenaline to save the kidney even. But your question is inotropic. Yes, the combination with inotropic, but for me, the first, it should be one by one, not straight away. When we talk about inotropic, it's about the function of the heart. And the heart can be affected by sepsis. But noradrenaline itself has a positive effect on the heart. It is an inotropic agent by itself. But if after starting the noradrenaline, crossing the 0.5 mic per kilo per minute, this is when you should consider to add dobutamine if there are other parameters showing that the circulation is not good, the macrocirculation is not good, for example, the CRT is still prolonged, for example. So this is when you should add that as a second agent. By the way, when you want to start the dobutamine, dobutamine is good for patient with failure, but beware that it could also cause vasodilatation and drop the blood pressure. You need to have the diastolic blood the systolic at least 80, the diastolic around 60 for you to start a dobutamine. If not, you may have a blood pressure drop. Soalan kedua, salah satu tanda sepsis laktat lebih dari 2 milimol. Waspada jika pasien memakai salbutamol. Berapakah angka laktat yang bermakna dan evaluasi? The lactate number can be affected by salbutamol, can be affected by various other things. Whether in the sepsis it has caused transaminitis, affects the liver function, whether adrenaline has been used. All this makes the interpretation of lactate tidak begitu tepat. Jadi untuk membuat interpretasi yang tepat, kita harus mengambil kira the surrounding external factors that can cause the rise of the lactate. How high the number I cannot give you because it's generally is just higher, but there's no like I could say that because patient has liver, we expect it to be how many % higher. I do not know because every patient is different and it has to be individualized. So I'm just saying that in general understanding, the lactate would be higher from sepsis alone, septic shock alone. But if there are no other external factors, it should be coming less than 2. That would indicate that we have successfully resuscitated this patient with a good macrocirculation. So itu jawapan saya untuk Avitri. Okay. In the dengue shock syndrome, Awande, with lung edema, dengue shock syndrome with lung edema, what is the best fluid we must use to resuscitate intravascular volume but not make worse the lung edema. This is very difficult to manage, because when we talk about dengue shock syndrome, we're talking about a leakage problem, especially if the platelet is less than 50,000. And not typically we get acute pulmonary edema. We can get pleural effusion, we can get ascites, with pulmonary edema it's possible, but for such extent we have to manage just like we manage the pulmonary edema. So it's very difficult to balance with the need of the fluid while the patient is having the pulmonary edema at the same time. So I think it's a question of balance, but the question is the best fluid. In resuscitation, the best fluid is still a balanced fluid. It has been studied in a large trial in America that studied its use in both ICU and the ED, the SMART trial. And they recommend a balanced fluid. So if you have a choice, go with the balanced fluid to address that. So yeah, so but again, this is very difficult situation in giving fluid and not worsening the pulmonary edema is pretty hard. You may have to combine such patient with the non-invasive ventilation to clear the pulmonary edema, and while at the same time looking at the patient fluid inside the pipes, in the sense that you would be assessing the adequacy of the fluid you could use with the your ultrasound, your echo, looking at the size of the chamber, looking at the IVC, just making sure inside there's enough fluid. Remember, pulmonary edema doesn't mean excessive fluid necessarily. Yeah, you may have a leakage problem, but inside the vessels, inside the pipe, you may not have enough fluid to make sure that the macro and macro circulation are addressed. So I think in answering your question, which is very complex, number one, we still need to make sure the inside the vessels there's adequate fluid, but not too much. And you could use the parameters just now. But number two, in handling the pulmonary edema, if it is acute pulmonary edema, you may have to supplement the use of the mechanical assistance, even intubate the patient if need be. And number three, in terms of the fluid choice, we're talking about dengue. It's not bacterial, it's viral. So, but still, it could affect the glycophilics, for example, causing the leakage, and in resuscitating the fluid, if you have the means to balance fluid, that would be better. Yeah.
Okay. Yeah. Good question and good answer. Mungkin bisa menjadi pilihan using albumin, 5% albumin.
Yeah, betul. Kalau 5%, we would use, that is the point lah. When we have the leakage, the albumin, we also use albumin at the point of any point there's a leakage. If there is, for example, we see especially with the platelet less than 50,000, because the paper have shown leakage happens when the platelet is less than 50,000, number one. Number two, any signs of leakage, which may be pleural effusion, which may be pericardial effusion, which may be ascites, such patient, we start albumin straight away. Yeah.
Ya, kuncinya adalah individualis ya, Alza. Jadi untuk pertanyaan terakhirnya Wanda, with patient. Jadi tadi sudah dijelaskan oleh Dr. Alza, dengan pulmonary lung edema, perhaps we should ventilate the patient with mechanical ventilation, intubate and ventilate, and then still we have to give the food for the patient. Nah, sudah dijelaskan tadi untuk choice-nya, Awanda cukup jelas. Ya, any other question? Kalau tidak, saya tunggu-tunggu sekali. Dr. Alza biasanya punya puisi. Ya, pengetahuan saya Dr. Alza suka membuat puisi, sering bernyanyi. Any other question? Ini untuk septic shock. Mungkin kalau tidak ada pertanyaan lagi,
ya.
Saya buat konklusi dulu. Saya buat kesimpulan dulu dari presentasi kita pagi ini. Ya, jadi pilar dari resusitasi hemodinamik masih tidak banyak berubah, tapi kuncinya adalah individualisasi. Ya. Jadi tadi ada banyak konsep-konsep yang sedang berkembang, walaupun mungkin belum terlalu terbukti ya Dr. Alza untuk beneficialnya. Beberapa aspek untuk makrosirkulasi dan mikrosirkulasi tadi sudah dijelaskan dengan sangat rinci dan baik, karena ini ilmu yang amat sangat berkembang, jadi masih dibutuhkan banyak riset tentang ini. Angka tidak terlalu jadi patokan utama kita. Jadi jangan terlalu percaya dengan angka-angka 30 ataupun itu, semuanya individualisasi dari pasiennya. Banyak yang pelajaran sekali hari ini, Dr. Alza. Ya, untuk microcirculatory endpoints resuscitation, saya garis bawahi di sini ada saturasi vena sentral lebih dari 70% ini, karena di sini banyak murid-murid saya mungkin mereka kadang-kadang harus mengingat dengan angka juga. Kemudian vena dan arteri karbon dioksida gap yang kurang dari 6, laktat kurang dari 2, capillary refill time kurang dari 3 detik, urine output lebih dari setengah cc per kilogram berat badan. Itu endpoints dari baiknya mikrosirkulasi dari pasien. Target kita menyelamatkan mikrosirkulasi, bukan hanya makrosirkulasi, supaya tidak berkembang menjadi gagal organ. Kalau sudah gagal organ, ending semuanya. Mungkin itu kesimpulan kuliah kita hari ini. Saya mau kasih hadiah pantun lagi untuk Dr. Alza. Dr. Alza ini punya putri 1 orang, Rin. Saya suka lihatnya karena hubungannya lucu dan very cute, both of you. Ini pantun hadiah untuk Dr. Alza. Di kota Berlin banyak melati putih buat narsis. Dr. Alza tahu narsis. Semua audien yang kami hormati, terima kasih menyimak presentasi sepsis. Ada banyak sekali yang menarik dari a very good friend of mine. Saya catat beberapa, boleh Dr. Alza ya untuk saya share ke my students. Dr. Alza ada buat tulisan. Bila setiap tetes air bersatu, hasilnya adalah lautan. So, if we believe in teamwork, ya, 1 tetes air pun kalau kita bergabung bersatu, hasilnya nanti akan menjadi lautan. Satu lagi ini juga saya outline sekali buat saya. You are the editor of your life. Ya. Jadi keep the good and throw out the bad. Bagus banget ini Dr. Alza. Jadi I believe dengan banyaknya CV Dr. Alza yang sampai halaman ini, beliau masih bisa bilang, saya orang yang biasa, hanya seorang dokter dengan 1 istri, 1 anak, kepala boleh setinggi angkasa, setinggi langit, tapi kaki harus menjejak bumi. Itu yang saya artikan di bahasa kami.
Ya.
Saya harap Dr. Alza pernah datang ke Pekanbaru 1 kali, saya harap dengan sudah dibukanya direct flight kembali. COVID sudah mulai mereda, saya berharap Dr. Alza mau saya jemput lagi untuk kembali datang ke sini. Mudah-mudahan ini bukan kuliah yang terakhir, saya masih menantikan share ilmu, share informasi, share puisi, share nyanyian. Kalau follow IG-nya Dr. Alza sering share nyanyiannya. Share nyanyian, share puisi. Mudah-mudahan ini tidak yang terakhir, kita tetap kontak, tetap mau datang ke sini. Saya harap juga saya bisa ikut datang ke sana.
Insya Allah, insya Allah. Saya ingin sebelum berundur, saya ada membuat satu puisi. Sebenarnya kemarin ada satu webinar berkenaan dengan insiden Kanjuruhan di Malang yang melibatkan kematian ramai penonton bola. Jadi saya diminta untuk membuat rakan baik saya di Jakarta untuk membuat satu puisi belasungkawa untuk insiden tersebut yang harapnya menyembuhkan. Jadi saya telah meletakkan perkataan yang saya fikir mendalam. Kalau diizinkan sebelum kita berundur, boleh saya bacakan puisi tersebut?
Boleh.
Saya kongsikan di sini sebentar. Sebentar ya. Sebentar saja. Sekejap. Nanti saya share dulu sekejap ya. Bisa nampak?
Belum lagi.
Oh, resume share. Sebentar ya, something wrong. Sekejap ya. Sorry. Sekejap ya. Sebentar. Sekejap saja. Okay. Saya cuba sekali lagi ya. Sorry ya. Okay. Should be it. Sorry. Bisa nampak? Sekarang nampak? Nampak tak? Nampak tak? Bisa nampak?
Nampak, Dok?
Nampak ya? So, saya mulakan ya. Bola kasih untuk semua. Mereka adalah sebahagian dari kita dengan hatinya setia untuk pasukan yang ada. Hadir untuk memberi suara, sorak dan sokong seadanya dengan harap menangnya ada. Pada putar ligat sebuah bola di atas padang tamasya. Bola itu berputar pergi ke sana, ke sini, ke hujung dan ke tepi. Pada laras dan tendang kaki, semua yang berkeringat sepi. Dalam menang itu dicari. Namun, pada akhir sudah, untuk menang harus ada yang kalah. Untuk juara harus ada yang rebah. Untuk berjaya harus ada yang pasrah. Namun semalam, kita semua berduka. Semuanya hanya kerana sebuah bola membawa banjir dari semua air mata. Lalu kita semua tewas dan tiada siapa pun juara. Kerana sebuah bola, ada yang parah dan terluka. Ada yang hilang seluruh nyawa, rebah dalam 1000 duka, tersungkur dalam sejuta kecewa. Kita menangis sedih tidak terhingga hanya kerana sebuah bola bisa memutarkan kisah luka, sebuah nasib yang malangnya tidak tercerita. Kita menangis sedih dan sepi kerana anak muda, suami dan isteri seharusnya kembali pulang ke sisi, tidak kira kalah, menang atau seri. Namun semuanya kini sunyi dan hibanya belum dapat pergi. Dalam perginya mereka meninggalkan pesan kepada kita bahawa tidak kira siapa pun yang juara, kita tidak seharusnya kalah atau kecewa. Mereka yang pergi menemui Nisan mungkin mahu memberi pesan bahawa kita harus hidup dengan persahabatan, perlu bebas dari persengketaan, harus mendepani semua kekecewaan dan bangkit dengan sejuta kekuatan. Hatta dalam kalah masih ada kemenangan jika perhubungan tetap utuh dan bersambungan. Setiap mereka yang pergi dan telah tiada memberikan nota akhir untuk kita bahawa hidup ini tidak lama untuk kita bermusuh atau bersengketa. Penuhilah ia dengan kasih dan mesra. Isilah ia dengan cinta dan mulia. Moga tiada lagi ada bola benci dan sengsara sesama kita. Dan yang ada untuk semua adalah hantaran bola yang padanya terisi kasih, mulia, dan cinta. Sekian, terima kasih. Semoga anda semua diberkati Tuhan. Dan sehingga kita berjumpa lagi insya-Allah satu masa. Dan salam dari Malaysia. Okey, Doktor.
Kita foto bersama dulu.
Oh, okey, foto bersama. Yap.
Ya, buka
Okay? Okay, semua salam.
Terima kasih Dr. Elza.
Oke.
Salam dari Pekanbaru.
Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih Dr. Elza.
Selamat.